Welcome, everyone. Give us just a moment while our live stream gets started. All right, Dr. Lateeb, take it away.
Right. Good morning, everyone. Good afternoon to some of you if you're joining from far away. And really welcome to the SCAI Interactive CME mini-series. As you know, we have 3 of these in the series, looking at technical mastery and really how to guide with proper imaging, using lesion preparation to really get the best out of coronary drug-coated balloons. Today, we're specifically going to be looking at how coronary drug-coated balloons are used in de novo lesions, small vessels, and bifurcations. And really, we're lucky to have some of our European colleagues, or many of us with European experience, who will be sharing how these balloons are being used in everyday practice. So I'm Azim Lateef from New York, and I'm really honored and delighted to be joined by an incredible panel. Will be sharing their cases with us. We have Antonio Colombo, who will be sharing a case of de novo lesions, followed by Tanvir Rab, who will be taking us through a long lesion involving a bifurcation in the patient with ACS, and Bernardo Cortese, who will be talking about small vessels. Here you see our disclosures. This webinar is supported by an unrestricted educational grant from Boston Scientific that has the only approved drug-coated balloon in the United States, the Asian drug-coated balloon. So we'll be showing some cases with that too. And I want to remind everybody that this activity does have CME, and you can apply for CME credits after completing the activity. And you just use your SCAI Online Learning Center to do that, and you'll get an email after the webinar concludes. So without further ado, we'd love to get really into the cases. Thank you, Antonio, Bernardo, and Tanvir for joining us today. I'm looking for a really interactive and enjoyable session. To those of you joining, we're here to answer your questions. We're going to show you a case, but we want this to be interactive. Please type your questions into the chat, into the Q&A, whichever you prefer, and we'll make sure we try and get through most, if not all of them. So, Antonio, would you like to start with your case?
Thank you very much, Azim, and thank you, SCAI, for this opportunity. I'm going to share my screen, and you let me know if you see the first slide with the title, When DCB PCI. Do you see the slide?
Yeah, we're all good, Antonio.
So I have no conflict to disclose regarding this presentation. So I like always to start with this slide that you may have seen several times, but I like to use DCB not as a competitor of stenting, but as an integration of drug-eluting stent. And that's the reason why I call it pragmatic approach to simplify the procedure when maybe you can still place a stent but becomes more complex, and I will show some example. To avoid full metal jacket, especially for long lesion on the left anterior descending. We all know the issue of small septals, diagonals, etc. And in high bleeding risk, I know that with DS you can have a very short dual antiplatelet. Nevertheless, if you implant many DS, the problem may not be so straightforward. So I think if you minimize DS in high bleeding risk patient, that may be an advantage. And this to me is one of the most typical examples where if you do not place a stent and you can get away, the procedure gets simplified. You see this trifurcation. The LAD left main is not critical, but the other 2 lesions are critical. If you implant a stent in any of the 2 branches, you're going to get carina shift, maybe towards the LAD, and then the other branch. It becomes a laborious procedure. You can conclude, no question, but becomes laborious. We did 2 balloon inflation, kissing, and this immediate result. And we did the DES, is not a stent-like result, but you see there is no stents, left main is uncompromised. There is some residual lesion, but nothing is critical. and the procedure is done not only in the interest of time. Our goal is not to be quick, but our goal is to be reasonable for the patient, and for this patient, avoiding stenting the LAD and the left main, if not needed, is definitely an advantage. So this is what I call simplification. This is another example. You see this long diffuse disease of this small circumflex. Of course, if the patient is asymptomatic, it's better to do nothing, because this could be a headache if you have to implant stents. But if you don't have DCB, stenting the ostial circumflex is not always simple regarding the long-term outcome. Immediate outcome is not complex, but in this case, doing DCB, minimizing carina shift, and this is the result after 1 year. You see good lumen in the circumflex, no carina shift, no need to stent the proximal LAD or the left main. And again, this goes into this philosophy. The second point is long diffuse disease of the LAD. Minimize the implantation of long DS. These are real long diffuse disease of the left anterior descending. You may opt for a straight implantation of a stent in the very proximal LAD and do the rest with the DCB, which is perfectly fine. Still goes in the philosophy to minimize stent length. So we did proximal dilatation with a 3 mm non-compliant balloon long, another dilatation with a 2.5 long. We did IVUS. We saw moderate calcium, 4 mm proximal, 3 mm distal. So we did more dilatation proximal with a non-compliant balloon at high pressure and in the mid. And when we treat this long disease, we like to measure PDPA, which is a pressure gradient distal to proximal. And this after pre-dilatation. The result again is not stent-like. There is a linear dissection in the proximal LAD. The PDPA was 96, so basically a minimal residual gradient. The result again is not stent-like, but is good runoff. Maybe there is some recoil in the proximal LAD, but the rest is fine. We should have used the trio long DCB. We checked the IVUS and the lumen was 6 proximal, 5 in the intermediate, and 4 square millimeter distal. And we thought at length and we acted conservatively. We implanted a long DS proximally and left all the other with DCB, which is an acceptable approach. Honestly, is not a must, but at this point of our learning curve, I think to treat large proximal vessel with a stent is not inappropriate, and to treat the distal part of the vessel with a drug-coated balloon. But again, according to the pressure gradient, to the physiologic measurement, maybe we could have avoided the stent. And we did the rest with long drug-coated balloon. This is another example. You see, we did the pre-dilatation in the mid-LAD, and there is a linear dissection where there is a yellow arrow. We did the IVUS, and the IVUS residual lumen is 5.39. What I don't completely like is that there is some dye hanging at the end of the injection. Honestly, this was done last year. Maybe nowadays we will lumen is fine by IVUS. The dye hanging is not the main feature that we like to accept, and therefore we implanted a short stent just in that area because of the dye hanging. If there was no dye hanging at the end of the injection and the dye cleared immediately, we would have accepted the result. But again, we prefer to make a mistake toward extra safety than taking the risk for the patient to have a late occlusion. And by doing this philosophy, in the past 4 or 5 years, we did pretty well. And basically, we did not have a single acute occlusion. Despite the fact that the IVUS lumen was 6.6, the dye hanging made us to implant a stent. I want to finish with a more provocative example. Should we also include ideal lesion for DS if the result after pre-dilatation is optimal? Why, if the result is optimal, implant a stent routinely if the result is optimal? This proximal LAD, to me, is the typical lesion for the drug-eluting stent. Short, relatively short drug-eluting stent. You don't need to hang on the left main. Personally, I would not, but I know many operators may even hang on the left main, which will, in my opinion, be a little bit problematic because you cover the circumflex, etc. But we did regular pre-dilatation. After pre-dilatation with a 4 cutting balloon, we have a very good result. There is a linear dissection, but the dye clears immediately. And the residual lumen, we always do IVUS in these cases. If we don't go for stenting, you see the dissection, but you see the lumen, how large it is. The lumen predominates on the dissection. And in this case, we did not implant a stent. We would not have done these 2-3 years ago, but nowadays, if we double check with imaging and we see that the residual lumen is large, even in the typical lesion for stenting, we avoid the stenting. Thank you for your attention, and I open this presentation for discussion.
Thanks, Antonio. As always, you always find a way to be provocative towards the end of the presentation. But let's maybe start sort of more in the beginning and from the basics. So, we have on the call a lot of younger colleagues, some who are now more and more so, I think, getting exposure to drug-coated balloons. And you've shown us a lot of very sort of interesting cases, bifurcations, long lesions. Maybe just taking it back to the basics. I mean, part of getting a good result with a drug-coated balloon, you mentioned, is having good lesion preparation and minimal residual stenosis and not having a big dissection, right? So how do you get to that point? What are the tips, the Colombo tips and tricks to get that good result without a big dissection?
So first of all, you have to do a good angioplasty. A good angioplasty means that you have to use, if possible, non-compliant balloon, inflate the non-compliant balloon at high pressure, use angio 1-to-1. If you use IVUS, we like to do IVUS to check for calcium, know if we need some special device for calcium, and we undersize according to the media to media. If the media to media is 4, we use a 3.5 high pressure balloon. For stenting, we would be more aggressive, but we know that most of the lesion will dissect because it's very difficult to do a good angioplasty in many arteries, especially if they have diffuse disease, without creating a dissection. But you have to be creating a gentle dissection. I know that the word is easy to say, but it's not easy to perform. But if you don't oversize the balloon too much, size appropriately, don't undersize, because we don't have to massage the vessel, we need to dilate the vessel. So we create a dissection, but if we don't oversize, it's not a bad dissection. The other point is be liberal to use cutting balloon. Sometimes if you have a suboptimal result, before jumping to the stent, we go for the cutting balloon. And many times, if we do an additional dilatation with the cutting balloon, the result improve. And then at the end, don't feel culprit. If you don't like the result, you implant a stent. We don't have to send the patient to surgery in the old time. We have no alternatives. Now, if the result is unpleasant, we implant a stent.
Let me just because of some of the questions, just add a little bit to that, Antonio. When you're using these non-compliant balloons, do you prefer short balloons, long balloons?
Long balloon.
Long
balloon.
So
Long
20 to 30 millimeter balloons.
Yeah, 20, 30. Many labs don't have non-compliant balloon long 30. They only use non-compliant balloon to focally post-dilate stents. I know that. But nowadays with DCB, and then when you do an inflation, keep the balloon inflated at least 20 seconds. Keep the balloon inflated, don't up and down. You're not implanting, even for a stent, I like to keep 10, 15 seconds. But for angioplasty, look at the ceiling, look around, distract yourself, don't look at the balloon, talk with someone else, but keep the balloon inflated.
Right. Okay, great. So Bernard, I'm going to ask you this next question, and then we'll come back to Antonio. There's a lot of questions here about dissections, right? I mean, the colleagues are a little worried, what dissection do you leave, don't you leave? Especially when we see Antonio's case, really osteal LAD, when do you put a stent in? What's the risk of acute vessel closure? Now, you've done a lot of work looking at dissections and the risk of acute vessel closure. Do you want to share maybe some practical information with the colleagues?
In two projects, mainly we use angiography as a main decision making. Nothing wrong to do IVUS. By doing IVUS, you learn and you get more data, and you have to be a little bit more confident in what you leave. But if you leave angiography, two projections, always two projections. The residual lumen has to be adequate. For adequate, I mean acceptable. We know 30%, but we have to see a good residual lumen in two projections. The dissection is seen, no way not to see the dissection, will be present 40, 50% of the time, but the dye in the dissection lumen should clear as quickly as the dye in the lumen. So what we call dissection type A or B and some type C, but make sure to do two projections, residual lumen good and good dye clearing. That by angio. If you want to be super sure, do IVUS, not to see the dissection, but to evaluate how big is the residual lumen. The dissection is fighting against the residual lumen. If the residual lumen is big, the residual lumen will win over the dissection.
Okay.
Yeah, to add something on this, because I fully agree with that, and we underlined that in the DCB ARC paper that we published this year in the European Heart Journal. And to add some clinical data on this important technical information, paclitaxel specifically, but later we also observed that with sirolimus are drugs that are able to favor the healing of the dissection. And this is very important. In all of the clinical trials, which have investigated all of the drug-coated balloons so far, so different brands with angiographic or clinical follow-up, the risk of closure of the vessel is very low, very low. And if you see the data at 1 year, it's lower than historical data with a stent thrombosis in case of stents.
Okay, great.
So I had a couple of questions to ask. So do you ever go back with balloons or IVUS after you put a DCB? There's some thought that you shouldn't do that because it might displace the drug. And secondly, compared to the balloon angioplasty era, we have very potent dual antiplatelet agents, particularly prasugrel and ticagrelor. And I think the risk of abrupt closure probably due to that factor may be lower,
Yeah, so go ahead, Bernardo.
Yeah, very short. So I don't agree with that. So what we know from our data is that it's the anticoagulant that you're using in your lab, the heparin or bivalirudin, whatever, that is promoting and helping you not to have an acute and a very acute occlusion. The antiplatelets do not have a strong role on that. We have run a study, and also Thomas Rissanen did a study on a single antiplatelet therapy in high bleeding risk patients after DCB, and it's safe. But there are 2 randomized clinical trials running on this topic, so we will have to wait a couple of years more.
So
Yeah, but I think you should not do IVUS after DCB, not because of the drug, but because you have to learn to use DCB only when you trust the result. It's a philosophical approach. You cannot change, you get married tomorrow, you cannot change your mind the day before.
So Antonio, actually, there's going to be some data. I'm going to show you guys some pictures soon. I was just recently in the Visible Heart Lab where I spent the whole day using drug-coated balloons and watching with angioscopy. You can see the drug delivered, and it's amazing when you stick an IVUS or OCT catheter, because of the wire bias, wherever that wire touches the wall, you scrape off the drug.
Oh, yeah?
Oh.
So you actually lose the drug. And if you go through it with a balloon, okay, or even a stent, an undeployed stent, you scrape off more drug, okay? And so I'm trying to prepare this. We just did this a week ago, 10 days ago. So everything we've said in the past, actually, there's now physical evidence I can show you, and you see the drug coming off the wall. So I do think
that's very important.
That's very interesting. Very interesting.
That's another more important reason than what I said. Not only philosophical, is a practical reason not to do it.
Absolutely.
So we don't do it. We don't do it not for what you told us, and I'm going to take this as a good lesson. And so we'll have 2 reasons, philosophical and practical.
Yep, absolutely. Well, we're going to keep moving. I know there's a lot of questions here, and I promise you we'll try and get through many of these questions with the next cases because there'll be some repetition. We do have a quick poll. So can we bring up the poll, Kristen? And here we go. So you will see the question there. I'll read it out. When considering the use of coronary drug-coated balloons for de novo lesions, which of the following factors is most critical in determining the success of the treatment? You have one choice. It's the patient's history of diabetes, the lesion's calcification vessel size, the presence of a CTO, or the final lumen area after lesion preparation. Unfortunately, I can't vote, but
I can vote as well, yeah.
I cannot vote. I think I
I'm not sure I know the answer, but yeah.
Hopefully.
We start seeing the answers. What do you think?
Great.
I think they were listening. I think that everybody was listening.
Great job.
Good work. That's exactly the right answer. So let's go into the next case. I'm not going to forget your questions. We're going to try and bring in some of the important questions in the next cases too. So Tanvir, do you want to share the next case with us?
I don't know why it's not minimizing my screen. Can you all see it?
Yes, we can. Why don't you go in presentation view?
Sure.
Maybe we'll see then. Okay, so we're seeing the presenter view, so just change the display settings. There you go, maybe.
Let me go back. I think
Fantastic. Okay.
Back some slides. So I'm going to talk about DCB and de novo, small vessel long lesions involving bifurcation. So this is a case, a recent case. I have no disclosures. This is just a case that came recently. 60-year-old male who unfortunately has male breast cancer and has which is metastatic. He's had a right mastectomy and is on chemotherapy, radiation therapy. There's chronic therapy with Ibrance. He came with acute coronary syndrome with dynamic infralateral EKG changes. The highest sensitive troponin was 1492, and his creatinine was up at 1.4. He has hypolipidemia, which is untreated. So this is ECG, which demonstrates the T-wave change in the infralateral leads. By the time we saw him, the cardiology team, his chest pain had subsided, but he was stratified to an urgent cath. So this is his pictures of the ventriculogram. Emory uses multipurpose catheter, but if you notice, putting in the lateral view, his lateral wall is hypokinetic. His EDP was up at 22. So these are his angiograms. There's very mild distal left main disease. You can see clearly that he has a lot of disease in the circumflex, both proximally and distally in the two marginals. The second marginal is subtotally occluded. The left side, you'll see that he has a very tight, high first diagonal. The largest second diagonal has a tight stenosis, and he's got a long lesion, not quite involving the ostium or the LAD, but probably just from the first diagonal down to the mid LAD. Let that play for a minute, okay? And then his right coronary artery has moderate disease proximally, and his multipurpose catheter is 6 French is 2 millimeters, but as you can see, there's a 2 millimeter vessel distally. We also diffuse the disease with small distal right system. So at this point, he's not a candidate for CABG. He's got multivessel disease, and so as you know, the agent balloon is limited in distribution, really for instant restenosis. We don't have all the sizes, but clearly looking at the ventriculogram, probably circumference was culprit more than the diagonal, in my opinion. But we do not have the specific agent balloons that we would like to touch the circumflex with. But we went and proceeded, and at that setting, the first day we just went and treated the diagonal with a drug-coated stent, and the prox to mid-LAD reached a very long 3.5 or 48 millimeter drug-coated stent with a 4 balloon proximally. So that was the first day, and then we brought him back the next day. He was clinically stable without any chest pain symptoms. He was treated with DAP with aspirin and prasugrel. And the next day he came back to the lab after we had the special balloons in place. So this was his anatomy the next day. And you can see that this is what his circumflex looks like. His second marginal vessel is as stated, is subtotal distally, and there's long disease proximally. There's also disease in the first marginal vessel. So we have small vessels proximally and distally, and we involve two bifurcations. Certainly the lesion in the circumflex goes back to the ostium, and this is, in my opinion, the left main is less than 50% stenotic, so it's really a Medina 001 lesion at that point. And for this bifurcation, the lesion is within 4 millimeters of the bifurcation. So again, it's a bifurcation lesion, probably a 001. If anyone disagrees, let me know. So this is the patient with ACS non-STEMI. He has multivessel disease, not a candidate for CABG, which has metastatic male breast cancer, the radiation of the chest, small caliber left circumflex and second marginal, involves two bifurcations. If you stent at the ostium of the left circumflex, likely to extend the left main, and left main PCI stenting should be avoided. There are long lesions with total anticipated length to be greater than 60 millimeters. In this case, we have to justify in the United States the need for de novo lesions. That treatment DCB is justified. So what we did first, we did 2.0 by 20 semi-compliant balloon. We didn't have a longer balloon at that time for the second marginal. And we did not IVUS at that time, but we took a 2.5 by 30 semi-compliant balloon and the proximal circ going back to the ostium. Now, I will tell you that the circumflex was very difficult to wire at the ostium. We used a workhorse wires such as run through and whisper. Didn't work. So we actually had to use a filter XT and a turnpike microcatheter to be able to get into the ostial circ. And I placed that microcatheter distally, changed that to a wiggle wire, which became a wire that we worked on. So this is the post-PTCA result. We have a type B dissection here. The linear shadow is really a small branch of the second marginal vessel is now open. And at this point, after we looked at this, we went ahead and did an IVUS. And this is IVUS starting just doing second marginal back. It measured at 2 millimeter reference diameter. You can see a small dissection coming up soon, right there. And the lumen does not look terribly compromised. We went back to the mid-circ, was a little ectatic maybe. And when we come back proximal to that, you'll again notice a dissection that will come on right there, some calcification there. You can 11 to 12, and you come back. And towards the ostium, you'll notice as we come back, there is calcification of the ostium of the circumflex. And the reference diameter in the left circumflex was 3.2 with a lesion length of 28. Coming back to the osteum. There's the calcification of the osteum. All right. So what we did in this case then, we did the osteum was calcified. I used a 3/6 Wolverine cutting balloon, inflated it to 6 atmospheres times 3. And this is the result of the cutting balloon that you'll see. Still has a dissection in the right above the bifurcation, and probably a little bit of the osteum circumflex too.
So sorry to interrupt, Anvir. You just inflated the Wolverine at 6 atmosphere at the osteum, but not at the dissection site, if I understand well.
Correct.
All right. Okay.
Right, just for the osteum only. But the osteum, as you notice, had that irregular calcification right where it entered the left main. And I was not happy. But osteal circs reached to nose. And Dr. Colombo, any opinion about the Wolverine cutting balloon, the osteum? Or you?
I think it's a good idea to use the Wolverine as the osteum. The result is very acceptable. Even at the site of the dissection, you could, as Bernardo pointed out, maybe you could have also done an inflation of the cutting balloon at the dissection site. Usually you make the residual lumen a little bit larger, but I don't think it's a must.
Are you not worried about perforation if I did that? I mean,
No,
I don't undersize the balloon.
As long as you don't oversize, and if you don't go to super high pressure below 10, usually, of course, if I have any doubt, I do IVUS to check, because nowadays we know we should avoid what can be avoidable, but I think the circumflex is still 3 millimeter.
Tanvir, what I would have done here, I would have used a smaller cutting, 2.5, bringing it to very high pressures, like 18, like 16, going slowly, maybe twice or 3 times. And I would have done the same at the osteum, great idea, and also the dissection plan, but not the trio. I agree with you, not the trio, the 2.5 at high pressure.
So the 3 point.
I think the result is fine. I think I like to see another projection, but in this projection, I think the result is ready for DCB.
Okay, so that's what you did.
So let's maybe move on, and then we can talk a little bit about technique and these questions at the end.
So I used a 2/30 agent paclitaxel balloon that inflated up for 3 minutes, and patient tolerated that pretty well. Okay.
Okay.
And then I went on to the next picture. I brought the 3/30 agent balloon. These are special orders, so they came in. We know the patient had no symptom, but his systolic pressure dropped from 140 slowly down 90. And I checked the flow. There's no flow in the LE, so I deflated it, pushed the balloon down a little bit, and kept it again for another 60 seconds. When we talk about how long the inflation should be. Later. And then this is the post-DCB result.
I think it's fine.
And then I took a picture like 10 minutes later. I pulled the wire, and then 10 minutes later, I took this picture. And this is what it looks like.
So you kept the patient on the table for 10 minutes?
Yeah.
Okay, we'll talk about that in a moment too, because it addresses some of the questions from the colleagues.
So in this case, DCB was justified. We did image-guided balloon PTC and DCB. It's a déjà vu for me to go back to balloon PTC era. That's how I trained and practiced for many years before stents came along. And this is a non-flow limiting, stable type B dissection, did not require stenting. We need to accept the results because dissections will heal. We cannot expect a pristine stent-like result. Patient was chest pain free with no ECG changes during or post-procedure. We will continue aspirin pressure for that should be 12 months along guideline duration medical therapy, because that's our recommendation for ACs non-stenting. I'll do a follow-up angiogram in 3 months and probably treat the residual disease in the distal right coronary with a drug-coated balloon. Thank you.
Thank you, Tanvir. It was a great case, excellent case. Antonio, this point that Tanvir made, he kept the patient on the table 10 minutes, highlights a lot of the questions coming from the young colleagues. So, they keep asking, should we treat these patients differently if you're doing DCBs? Should you use stronger antiplatelets? Is there a role for I'm just going to summarize all the questions, right? Is there a role for glycoprotein 2B3A inhibitors? Is there a role for staying on heparin longer? Or would you keep them in the hospital longer than the patient you put stents in? Because, often I send I did 4 left mains yesterday. They all went home the same day. If I'm doing drug-coated balloons, should I keep them overnight? Is some of the questions coming through. What do you do in your practice?
But I think I think there is a learning curve on the operator. So at the beginning, I see nothing wrong to wait 5, 8 minutes, maybe not 10, but 10 minutes. After a while, you don't need to do that. If we have doubts, we prefer to do IVUS, check the residual lumen, and that will give us an immediate answer. Sometimes we do pressure wire, and that's also, if we like to see a gradient less than 10, that gives us reassurance. But at the beginning, in the first few months, I think be on the safe side and keep the patient on the table 5, 6 minutes is fine. Usually, I think it depends on the result. If you are not absolutely sure, keep the patient overnight is okay. At the beginning, I will not send the patient home same day, unless maybe it's a real small vessel, but I think I prefer to send him next day. I will not give extra heparin. I will not give 2B3As. You should not make the procedure more complicated. Otherwise, you place a stent.
No, we're on the learning curve. That's why, I thought I'd be safe,
Bernardo, so there's a lot of questions here. I wanted you to address 2 because you're very good at the technical stuff. So there's a lot of questions about inflation time with these balloons. What, number one, is it a risk? You're inflating so long, is the patient going to become ischemic? How long should you inflate the balloon for? Is it 30? Is it 90? Some people are saying 2 minutes and they just leave it inflated longer. Is there an advantage, disadvantage? And then with that, any difference between paclitaxel and limus?
Yeah, so there are many questions, and these are among the most important topics. I would say that what we usually do is we also during the pre-dilatation, we go with a little bit longer inflation, and we go also more recently with the repeated inflations. So this is aiming at having a sort of preconditioning for the myocardium, allowing a longer inflation of DCB. And now comes the second question. So why should we inflate the DCB longer than 30 or 60 seconds if all of the animal data have shown that 30 seconds are enough? So 30 seconds are enough. You should not go below 30 if you don't have, chest pain, but 30 seconds is a minimum. We usually go for 60 or even more because we have seen from the POBA era, and we have relearned with the DCB that the longer inflation is associated with a sort of scaffolding effect of DCB. So the longer inflations of a DCB are associated with a lower risk of recoil and the lower risk of bailout stenting. We showed that in a sub-analysis of ISBON study. So this is why you usually go for 60 seconds, and I would say 90% of the patients do tolerate this length of inflation.
Yeah, I totally agree with Bernardo. I think I will echo exactly what he said.
Difference between paclitaxel and sirolimus?
I have no data about that, so I don't think so. Yeah.
You showed very nicely in your case how the imaging was very useful to decide on balloon sizing, whether you were getting a good result. I think more and more we all accept that for restenosis, imaging is mandatory. But what about de novo disease? I mean, as you now are starting to use DCBs and de novo disease, and like you said, in the US, most of us are on the beginning of our learning curve. Do you think imaging should be standard when you're doing DCB and de novo disease, especially a case like the one you showed?
Oh, absolutely. And as you know, I'll reinforce that in our ACS guidelines we publish, we strongly encourage imaging for complex lesions. So it's a type 1 indication in this country. And of course, you brought the issue about using this de novo lesion. There's a question about will insurance approve. Actually, there's a session last time where we gave criteria, if we just justify it and document it well, as I did in this case for the reasons I showed you. Yes, insurance will support you, okay? So there is a change for that, just for our viewers to know that. You've got to justify why you're doing this case, which was very justifiable. Okay.
Yeah, yeah. And I would also argue that the NTAP payment doesn't specifically say ISR. So we've been very concerned in my center because I run the lab for 4 hospitals, and I was very concerned about the usage and would we get the payment. So we've been actually checking every month. Do we get paid when we've been using it for de novo disease? And we have gotten paid, particularly in the Medicare cases. Insurance, we try and get pre-authorization. So we definitely have. I'm just going to ask Bernardo very quickly, and then we're going to go to the poll. 2 questions here. The one is about, can you use the same DCB to treat 2 segments in the same vessel? Or once
No.
you use it, no?
Single shot.
Single shot, the drug's gone, right?
Yeah.
And then there's a lot of questions about scoring and cutting balloons. Right now, in ISR, we have a randomized study showing that if you use a scoring balloon, you get better outcomes as far as restenosis and intimal hyperplasia. Should we be using scoring or cutting balloons routinely in de novo disease?
So this is very interesting. It's a very well taken question. We don't have definite data. We are using more and more scoring balloon in fibrotic and moderately calcific lesions, scoring or cutting. Cutting has a more powerful effect for sure, but it's less deliverable. We only have one recently, not published but presented data by Patrick Sorayos. He presented a sub-analysis of a RECAGE-3-1 trial showing that there is a clinically evident advantage of using scoring balloon instead of semi-compliant or non-compliant balloons for lesion preparation in the DCB cohort of that trial. So that's the only, I would say, strong data that we have on the routine use of scoring balloons.
Yeah, we are more liberal to use these specialized balloons, especially before going to stenting. Many times we do an additional inflation with a cutting balloon, and many times we convert a poor result into a good result and we avoid stenting.
Yeah, absolutely. So let's go on to the next poll based on Tanvir's presentation. Can we have the poll up, please? So when selecting patients with ACS for treatment of long lesion bifurcation using drug-coated balloons, which of the following factors is most critical in ensuring optimal outcomes? The patient's adherence to DAPT, the presence of diabetes, the lesion's length and bifurcation angle, or the patient's history of myocardial infarction? I'll give you 20 more seconds to answer. Difficult question, this one.
Not easy.
Yeah. So Tanvir, you have to make sure we got the answer right here. So most people would say the lesion's length and bifurcation angle. I would probably say that's correct, but I do think also the DAPT one is also just as important in an ACS.
Yeah.
Do you want to make any comments, Tanvir?
No, I'm fine with that.
Okay, good. I think, honestly, I like both those answers. I think you guys did a great job with answering that.
Both are okay.
Yeah. Bernardo, we don't put small vessel on at the end because it's the least important.
Yeah.
Put it on at the end because it keeps everybody staying on the webinar till the end because it's the most frequent lesion we treat with de novo, right? So go ahead and take us through small vessels.
Yeah, I agree with you. And we had a short discussion yesterday on how we should go through this topic. And so we decided to keep it simple. So this is a quite a basic case with some hopefully useful information on how to deal with small coronary vessels. So this is my conflicts, nothing as pertains to this presentation. So we have to answer ourselves 2 questions. So we have a small vessel, a 2-5 third diagonal branch, which has certain prognostic value. And then we may have a middle AD with a recurrent and a PDA vessel and 2 or 3 diagonal branches afterwards. Same size, but prognostically, these vessels are really different. So the first question that we have to ask ourselves is, is this vessel relevant? And the second question, well, actually, it's I would say data. Data that we have is that with drug-eluting stents, the performance, any drug-eluting stents is lower. It's lower angiographically in terms of late loss, but it's also lower clinically. This is one of many studies showing that the rate of target lesion failure, for example, is much higher. And also the rate of thrombosis is much higher in the small vessel disease setting. So stents are good, but are not perfect in this specific setting. So I'm going to show you this case, which is a small vessel below 3 millimeters, but prognostically, I would say relevant. This is a lady, 46-year-old, with this diffuse disease. She had a diabetes, and I was doing this case in Serbia with this diffuse disease. The left main is paired, but we have a Medina 0110 with a trifurcation here involving also this ramus, which has a role, I would say. So I would consider, but I would not choose a DCB here. Why? I would consider because it's a big left main with a smaller LAD, so the discrepancy is like 50%. The difference in vessel size is 50%. And then it's a trifurcation. So I would consider DCB, but I would not choose a DCB until I prepare the lesion and see what we can achieve after lesion preparation. And then we come to what we did and published a few years ago on which are the tips and tricks on how to do a DCB PCI. So first of all, of course, clinical. Okay, so we don't have only to see the angiography, but we have to know our patients well. For example, if we have a patient at high bleeding risk, also with a prox LAD, I would recommend to insist a little bit more in preparing the lesion before deciding if to convert to a long stent instead of a DCB. Okay, so knowing the clinical profile of the patient is very important. Then you have to assess your lesion well. Usually, angiography is enough, I have to be honest, for small vessel disease. But if we are dealing with calcific vessels, if we are dealing with the ISR, if we are dealing with left main, too cool left main, imaging should be used. And we know that the guidelines are supporting us on this. But usually for the small vessels, angiography is enough. Then you have to prepare it with any tool. There is no restriction. Now we use ROTA, we use IVL, we use CSI, we use scoring balloon and cutting balloons more and more for preparing the lesion. I'm not saying that you have to use a specialty balloon or an atherectomy for all of the cases, of course, but we have all of the choices because we have seen that they are safe if the goal is to prepare correctly the lesion. And then you have to prepare it rigorously. We have seen from the cases by Antonio and Tanvir that you have to prepare the lesion, but if you don't have a good result, if you're not excited of the result, you have to step further to the next tool, which could be scoring balloon, cutting balloon, or whatever. Another important thing that is usually not that well emphasized is that to be gentle. You don't have to go. I have fellows that used to go 1 to 16 in 2 seconds. No, this is not a stent. And I would say that also with the stent, you should be a little bit careful. So with the predilatation balloons, not only with the DCB, which is the last part of this PCI, but with the predilatation balloon, go slowly. You don't need to go fast. Boom, okay? And then, as I said earlier, we should go for longer inflations. So this is what we try to do with this case. We use semi-compliant balloons for the distal LAD, for the prox LAD. Okay, this was a 2.5 by 17 atmospheres at nominal pressure, and we used a scoring balloon at a prox LAD, a 3.0 by 17. Okay, it was what we did. Then we predilated the ramus. Okay, we used the DCB for the ramus after lesion predilatation, and this is the result after preparation of the lesion of the LAD, which is decent, is not great, and is decent. And I want to emphasize the final result of the angioplasty of the ramus. Okay, so this is the type B, I would say. Yes, let's call it B dissection with a good fast flow and probably a good lumen. So this is why we decided to leave it. But we had to deal with the LAD. So we said, let's leave it there and let's reassess when we are finished with the LAD. And then we come to the second panel of tips and tricks on how to do a DCB PCI. So only after you are done with the DCB, sorry, with a good lesion preparation, and you are happy with it, you can decide if to use a DCB and a stent. So this is why I said you don't have to use a DCB in this case. You prepare and you reassess. If you are not happy, you have a 50, 60% recoil despite using whatever, go with a stent. But don't pay the entire coronary artery with a stent. Just put the stent where you don't have a good result. The option of blended therapy is one of the most fascinating and important ones. As Antonio was saying earlier, if you put a short stent in the proxial AD, it's not going to be a problem. If you put a trio stent well post-dilate in the proxial AD, a trio by 18, even 24, the risk of restenosis is very low. But if you pave completely the coronary artery of your patient, the risk of restenosis and thrombosis is high. Then you assess the result. As we said, 1 or 2 views. You wait for 5 to 6 minutes. More than that is, I agree, is going to be difficult in modern days. And then you assess it after this time in an orthogonal view, and then you are done. So we decided to go with a DCB. We used 2 DCBs in the prox and the ostial LAD. We did the POBA in the distal LAD because we had already used 3 DCBs. So it's I have to spend too much money. And this was the final result, okay, which is pretty good. Again, not a stent-like result. The dissection in the ramus did not get worse, so we decided to leave it as it is. Now, as I was mentioning earlier, we have some data from the experts, and Antonio and Azim are part of this important I would say 3-year-long environment with the DCB arc, where we go through all of this suggestion on when to leave a dissection and how to leave a dissection and when to convert on bailout stenting. I'm not going through that now. For this very patient, we also have an angiographic follow-up of after 4 months, which is showing how the ramus did not occlude. We don't have restenosis. We only have restenosis where we use the POBA in the distal LAD, but the rest of the LAD was fine. And now my 2 more slides, please, and which are related to what you shouldn't do. You shouldn't decide preliminarily to use a DCB until you got your final good lesion preparation. Don't never touch the device before insertion, and take care of transit. Transit should be fast, okay? Don't use a DCB as a dilatation tool. Still, folks are asking me, can I use it if I have a very simple lesion? No, prepare and then go with the DCB. And in case of bailout stenting, don't worry about that. Put a short stent where you just need it. My last slide is about the Andromeda meta-analysis, which is putting a lot of data on the small vessel disease management. This is a patient-level meta-analysis, 1,500 patients, and very fast, we show for the first time, after 3-year follow-up, a reduction in MACE with drug-coated balloons as compared to drug-eluting stents. I would stop here to leave some time for the discussion, if you agree, Azim.
Bernardo, thank you. That was excellent. It was really very, very good. I don't know, Antonio, any comments before we get into
I have a general comment regarding the proximal LAD. The final case I showed in my presentation, I think is a case that you come after a mature period. But my conclusion now is I put a stent if I really need it, not because the tradition tells me that in the proximal LAD you should place a stent. I like the tradition, but I think we should be scientific and modern. We have devices nowadays to know if the risk of closure is there or not. It's not at the time of PCI 20 years ago. We have IVUS, we have very many tools, and if the result on the proximal LAD is excellent, why do you place a stent? If after 2 weeks you get a car accident, and can occur, because people get car accident or a bicycle, and you have to stop antiplatelets after 3 weeks. If you have a stent, you get nervous. Nothing may happen, but you get very nervous. If you do not have a stent, you get nervous, but less nervous. So I think we should go over these idea that if I place a stent, I go home and I sleep. If you have trouble in sleeping, there are other tools.
But Antonio, I also know you very well, and I've worked with you for a very long time. And I want to get back to, what Tanvir mentioned, is there's a learning curve, right? Even
Yeah,
for you, it took many years before you
many
felt
years. It took
comfortable
many years. It
to
took
treat a
many years.
proximal LAD like that, right?
That's
So,
the reason why I showed this slide only today for the first time
right, right.
after 4 years.
Yeah. I think, for the colleagues, it's start with small vessels, if you're going to try to de novo experience, because that's where you learn and that's where the risks are smaller. Move on to maybe bifurcations and then move on to those long diffuse lesions as you gain your experience. But I think that, like you said, there's definitely a big learning curve. And I would say also the opposite though, right? I'm spending a lot of time like Bernardo's doing, teaching my colleagues who work with me how to use DCBs. And, recently, one of my colleagues had a long dissection, but he had already done the DCB and he was going to leave it alone, right? And I said, but, you don't have to feel bad about putting a stent in either. If there's a dissection you're nervous about, it's okay to put a stent in after the DCB. There are no additional risks from the double drug, but it is also, it's probably safer for that patient if the dissection looks ugly or looks concerning.
But one point that Bernardo stressed at the beginning, and I like to stress it again, is what he said. Should I use a DCB in this lesion? And the answer he gave to this question is, I don't know. The answer comes after predilatation. So you don't decide at the beginning. You decide after lesion preparation. And that Bernardo said that, and I like to reiterate.
Absolutely. And, just for everyone who's on this, even for all the clinical studies that are being done here in the United States on DCBs, the decision to enroll the patient, either randomize them or open the DCB is only done after lesion preparation, because repeatedly we've shown that good lesion preparation results in much better outcomes. So you don't even call for the DCB until you've gotten good lesion preparation, because until that point you don't know what you're going to do. Your decision is only made after great lesion preparation. So Bernardo, there were a couple of questions related to your presentation. I think this is a good one. If you see recoil after you have dilated, or even worse, after you've done the DCB and you see recoil in that area, what do you do?
That's a great question, and I had a terrible case last week about that. So we learned from the DCB arc, we created that, telling that you should leave a maximum 30% stenosis after DCB, unless it's within a very long lesion. In this case, you can also accept some focal 40-45%. Okay, that's fine. Sometimes you prepare the lesion perfectly using DCB and you have recoil. That's real life. It's quite uncommon, but it may happen. So far until today, I use another tool. I usually use like a scoring or a cutting balloon, and then I try to increase the vessel size. Now, probably from tomorrow, I will stop doing that for two reasons. One is what you taught us about the scratching of the drug in putting other devices, also imaging after DCB use. Secondly, in that very case, actually, I wanted to have a decent result. It was a 50%. So I used a cutting balloon and it ended up with a perforation. Okay, so it's rare. It's my first perforation with cutting balloon, I have to be honest. It's very rare, but you don't have to pursue, the good result. The perfect, we know we don't achieve with DCB, but also the good result. Sometimes you can also accept, some person stenosis. And if you have rest stenosis, it's gonna be much easier to treat if you have used a DCB instead of a drug-eluting stent.
Bernardo, can I ask you a question? When you had the perforation with the cutting balloon, what pressure did you inflate the cutting balloon?
Oh, that was not high. The vessel it was an ISR case, so we did IVUS. Vessel size was 3.2, and we use a trio at 12. It was not very high. No calcification.
And was an ISR. It wasn't.
Yeah, it was it was distal. It was an edge ISR, so that occurred just distally to the stent, without calcification, and I was surprised. Honestly, I was very surprised.
Okay.
And actually, it was just after cutting, there was a dissection, a nasty dissection.
Yeah.
So I waited for 2 or 3 more minutes, and in the end, it was a perforation.
So, guys, we're on the hour, so I want to get to the last question. We all love talking about DCBs. We could carry on for a long time, but I think it is a Saturday morning for everyone, so I don't want to keep you on the whole day. So let's bring up the last poll question, please, Kristen. So in small vessel disease PCI, it accounts for what percent of PCI in any center? We're trying to understand how common do you think small vessels are in our practice? Is it you see in 10 to 20% of cases, 20 to 40, 50 to 60, or 80 to 90? I think it also depends on how well you look for it, Bernardo. There's more of it there when you look for it, but anyway.
In my practice, 30%.
30%, yep. No, I think that's a fair number.
It depends on the cutoff, if it's 2.5, 2.75, or 3.0.
So what is your
in this case, I consider 3.0.
Less than 3.0? Okay.
3.0, yeah. And actually, it's more than 50 in my practice.
Okay.
It's more than 50%.
I think if you consider less than 3.0, then potentially yes. It is higher. I think if you were to consider maybe 2.5 or less, then it's probably 20%, 20 to 30%.
Yeah.
Okay. That's great.
Less than 3.0 is 2.5 or 3.0. I never look at water sizes. So
not 2.75.
Well, we don't keep water sizes. So we're on the hour. I want to really thank everyone. This has been, for me, one of the best webinars I've ever been at. And I don't say that lightly. And the reason I say that is because we've had 3 really great presentations. But more than that, the engagement from all the participants has been absolutely amazing. I've never seen this much questions, so much discussion, trying to respond to those questions. So to everybody who joined on a Saturday morning, really thank you. And thank you for making this webinar so interactive and so interesting. And to our esteemed speakers, thank you for giving up time on your Saturday to teach and to share your passion and love for DCBs. And thank you to SCAI and Boston Scientific for putting this together. Enjoy the rest of your weekend.
Thank you. Thanks a lot.
Enjoy the US Open.
Bye-bye.
Go Sinner.
Yeah. Sinner.